Hello students, in this segment I will discuss with you management of cardiac arrest victim through basic life support. Now basic life support can be given to a victim in cardiac arrest by a medical personnel or even by a lay personnel. And remember, the foundation of advanced cardiac life support is dependent upon a very good basic life support. Okay, so let us start. Now, sudden cardiac arrest occurs when the heart develops abnormal rhythm and stop pumping the blood. So, heart has developed an abnormal rhythm and it is now not effectively pumping the blood. So, there is no cardiac output, no perfusion, right? This is called sudden cardiac arrest, and it will immediately cause death in a patient if some emergency intervention is not done in the patient, and that emergency intervention is our basic life support. So remember, basic life support is not a definitive treatment, it's a first aid care given to a cardiac arrest victim. And one more thing you have to be very clear in your mind, like people interchangeably use the term cardiac arrest and heart attack. It's not the same. Cardiac arrest is more of a rhythm problem and heart attack is more of a perfusion problem. When the flow of blood to a particular area of the heart is affected, then it is called, then a heart, let's say heart attack develops. And let's say heart attack the symptoms of heart attack can be from days to weeks. It can vary from days to weeks, the duration of the symptoms, right? And heart attack can lead to cardiac arrest. But apart from, let's say, heart attack, there are so many other etiologies of cardiac arrest also. And in cardiac arrest, well, the symptom is acute, and if not managed, patient will not survive. Okay, so death will occur within minutes if victim does not receive immediate life-saving treatment. Now, what are the causes of sudden cardiac arrest? Coronary ischemia, that is the heart attack. Cardiomyopathies, structural heart lesions, electrical conduction abnormalities, metabolic causes, even so many hypokalemia, so many metabolic disorders, acidosis, etc. can cause a sudden cardiac arrest. Toxin, so many drugs can cause drug ingestion, toxin ingestion can cause sudden cardiac arrest. Electrocution can cause sudden cardiac arrest. Drowning can cause sudden cardiac arrest. So there is a variety of different clinical conditions which can lead to sudden cardiac arrest. And what is the only life-saving measure in this? Basic life support. Okay? And you know, 500,000 of the people worldwide, they have cardiac arrest out of the hospital. And only 10% survival is seen, right? Only such a little percentage of survival is seen. Even in hospital cardiac arrest, the survival percentage is still lower. Okay. So there are 4 rhythms of cardiac arrest, right? First one is ventricular fibrillation. Second one is pulseless ventricular tachycardia. Third is pulseless electrical activity and asystole. So there are 4 rhythms which can lead to cardiac arrest. I told you abnormal rhythm will lead to cardiac arrest, and these 4 abnormal rhythm leads to cardiac arrest. Okay. Of these, the first 2 are shockable. Ventricular fibrillation and pulseless ventricular tachycardia is shockable. And non-shockable one is pulseless electrical activity and asystole. In VF and PVT, right, the heart is having an abnormal rhythm, like in ventricular fibrillation, heart is fibrillating, blah, 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 heart is pumping like this. This is not an effective electrical, let's say, conduction impulse given by the heart for getting converted into mechanical output, right? So this blah, 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 blah electrical activity of the heart is not getting converted into mechanical output. That is not maintaining a cardiac output in the patient. So what we do, if we give shock to the patient and the heart stops, goes into standstill, and then if the heart resume its electrical activity, then we pray that that sinus rhythm is taken up by the heart, because the natural rhythm of the heart is sinus rhythm. So once the heart goes into standstill, then when it takes its activity again, then there is a probability that it will take the sinus rhythm. So that's why the shock is given. But when there is no activity of a heart, in just as in asystole or in pulseless electrical activity, which has other etiologies which you will study in the pulseless electrical activity chapter, there is no use of giving the let's say shock to the patient. Okay, but in BLS we don't have to recognize the type of rhythm. We just have to manage without recognizing the rhythm, because it has been designed in such a way that even a lay rescuer can follow it, not only medical personnel. Okay, so let us discuss about a clinical scenario, and accordingly we will discuss the basic life support. So I have a 62-year-old male walking in the park, suddenly collapses in front of me, and he has no pulse and no breathing, or let's say he suddenly collapses. Okay, now what I will do? What I will do in this situation? The first thing is I will do an initial assessment. The first thing, I will verify the scene safety. It's a possibility that the adult who has collapsed suddenly has collapsed beside a pool or in the middle of the road. So first thing I will do, I will make the scene safe both for him and for myself, right? So first is scene safety. I have to make the scene safe. Then if I am alone, then remember, alone you cannot continue resuscitation for a very long period. So what do? We call for help. So we shout for nearby help, and either we tell the help to activate the emergency system, or if no help is there, I activate the emergency system. So I call an ambulance and tell them that I have a victim who may be in cardiac arrest, though still I have not established it. I just have come across a collapsed victim. So I have not established cardiac arrest, but thinking that he may be in cardiac arrest, I tell the ambulance to come because I may have a cardiac arrest victim. After doing these three things, the next thing I have to do, I have to let's say confirm the victim is in cardiac arrest. Okay, and how can we confirm? By assessing two things: pulse and breathing of the victim. So I assess the victim for normal breathing and for the pulse. So what we do, we lay the victim on a flat surface, kneel beside the victim and feel for his pulse. Which pulse? I will tell you in 2 minutes. And look for the chest movement to assess the breathing. And both this pulse and breathing should not, the assessment of pulse and breathing should not take more than 10 seconds. Okay, so you can see this image. So what I am doing, I am assessing the pulse. Which pulse? Carotid. Carotid. Why carotid? Why carotid? Because if there is any cardiac output, this would be the last pulse to go. So if there is carotid, there is a cardiac output. So I would go for carotid, and I will put my eyes on the movement of the chest to assess the breathing. So remember, only carotid pulse is felt in adult. Victim's chest is examined for rise and fall. An agonal gasp like this is not a regular breathing. It is not a regular breathing. And in the initial stage of cardiac arrest, patient may have an agonal breath and will consider it as no breath. Got my point? So agonal breath means no breath. Okay. So now the further management would depend upon the presence of or absence of pulse and breathing. So let's say whether my patient has pulse or breathing not. So if my victim is breathing and a pulse is present, so carotid can be felt and breathing can be assessed. What will I do? I will just monitor the patient. I will just be beside the patient and wait for the ambulance to come. I will not leave a unresponsive victim alone. Okay. And what the maximum I can do, I can turn the victim in a recovery position, lateral position, so that he does not aspirate if he is full stomach. So I will make the victim in a recovery position. I will make the patient in a lateral position, and that's the recovery position which will prevent any aspiration in the victim, and wait for the ambulance to come. If the victim is not breathing normally and a pulse is present, no breathing, but there is a pulse, I can feel the pulse. right? Then it is a respiratory arrest, still not cardiac arrest. It will eventually go to the cardiac arrest, but still not cardiac arrest, it is respiratory arrest. So what will I do? I will give a breath every 8 seconds to the victim and do a pulse check every 2 minutes, because this situation may not remain for a long time. Patient may go into cardiac arrest. So I will go on giving the breath and I will do a pulse check every 2 minutes. Okay, every 8 seconds one breath, and every 2 minutes I will check for the carotid pulse again, right? If no breathing and pulse is also absent, then patient is in cardiac arrest. I have to begin with high quality CPR, high quality chest compression. So we begin with chest compression because it is CAB. CAB in cardiac arrest. We have to see circulation, maintain circulation, then airway, and then breathing. And there is a D also, that is defibrillation. So remember, before 2010, it was ABC, airway, breathing, and circulation. Now it is CAB. That is circulation, airway, and breathing. This is the sequence of doing CPR. So we always start with high quality chest compression. So we will start with chest compression. So when there is a single rescuer, right, the compression to ventilation ratio should be 30 compression to 2 breaths. 30:2, right, for any age of the patient. In adult, whether single or multiple rescuer, this is the ratio which we have to maintain in BLS. 30 compression followed by 2 ventilation, and we have to push hard. That is, we have to push so that 5 to 6 centimeter depression is there. So we have to push hard, and after pushing hard, we have to allow a complete recoil. When we allow the recoil, the heart gets filled at that time, so that when we push again, the perfusion is maintained. If we will not allow the recoil, then heart would not get filled. So we have to push fast and hard and allow a complete recoil. And we have to push fast. The rate should be 100 to 120 compression per minute. This is again a universal rate in all patients irrespective of any age in cardiac arrest. Okay? Okay. Now you can see in this image how we are giving the chest compression. The person who is the rescuer, he is on the side of the victim and he has placed his palm on the center of the chest, one palm, and what he has done with his other palm, he has put on the resting palm and interlocked his finger, and keeping his elbow straight, he is compressing so that we get a depth of 5 to 6 centimeter, and we maintain a rate of 100 to 120 compression per minute. Okay, so what are the points in the favor of high quality chest compression? This has been asked so many times in exam, that what are the features of high quality chest compression? You know, if you are doing good high quality chest compression, then also you can maintain only 30% of the cardiac output. And if you are not doing good high quality chest compression, you will not maintain that 30% also. So when we are resuscitating, the chest compression has to be high quality. So what are the features of high quality chest compression? Compress at the rate of 100 to 120 per minute. That is, push fast. Compress the chest at least 5 centimeter. That is between 5 to 6 centimeter. At least 5 is mandatory. Allow a complete chest recoil after compression. Now compression, the chest compression time should be 60 to 80% of the resuscitation time. Now during resuscitation, we have to do a chest compression, we have to give breath to the patient, we have to defibrillate, a lot of things we have to do. But in the entire resuscitation time, 60 to 80% time should be given to the chest compression. We have to minimize the interruption. There should be minimal interruption in chest compression. And just adequate ventilation. Avoid hyperventilation. We don't have to hyperventilate. The breath rate should be between, let's say, 8 to 10 breath per minute. Not more than this if it is independent of compression. right? If the ratio, we are not following ratio and an airway has been put, right, then the breath rate should be 8 to 10 breath per minute. And if we are following the ratio, then 30 compression followed by 2 ventilation. And when we are ventilating, it should be just adequate ventilation, not over ventilation. If we will over ventilate, then two problems can happen. One, let's say intrathoracic pressure would increase and cardiac output would reduce because of decreased venous return. Or patient can aspirate if he is full stomach. Okay, so over ventilation is not done, just adequate ventilation. Okay, so all these are points for high quality chest compression, which is so frequently asked in exam. Recent questions has been asked on high quality chest compression. Okay, what are the steps? As I told you, we will revise it again. We position at the side of the victim. Make sure the victim is lying face up and lying on a firm surface. Firm surface is very important. See guys, if I have not put the patient on a firm surface, I will do a chest compression and the body will, what will happen? The body would sink into that not firm surface. So what will happen? The heart will not get compressed between the first surface and our firm surface and our compression. So we have to put the victim on the firm surface for a good chest compression. Okay. Position your hands and body to perform chest compression. Put the heel of one hand in the center of the victim's chest on the lower half of the breastbone. Every point is important because each and every point about BLS is asked in exam. So where you have to put your palm? On the lower half of the breastbone. Put the heel of your other arm on the top of the first one. Straighten the arm, position beside the victim and your shoulder just above your hand, and you give the compression. So you give the compression, you give 100 to 120 compression in a minute. And if I am following the ratio, then once I have given the 30 compression, and if I have another person at the airway, he will give the breath now. Or if I am alone, after 30 compression, I will open the airway and give 2 breath to the patient. So now I will give the breaths. How I will give the breath? First, I have to open the airway. By 2 maneuvers, we can open the airway. So many times in my different videos, I have told you. Head tilt and chin lift and jaw thrust. For head tilt and chin lift, we tilt the head backward and lift the chin. This opens and creates an unobstructed pathway because it lifts the tongue away from falling. This tongue is falling on the airway. So when we do a head tilt and chin lift, the tongue is getting lifted up and unobstructed passage is created for the air to go. If I cannot do this maneuver, then I go for jaw thrust, in which we keep the head and neck in a we stabilize the head and neck, keep it in a neutral position, the head in neutral position. We don't move the head of the victim, and we stabilize the head with both our palm, and with our thumb we protrude the jaw forward. Okay, so this will again do the same thing. It will also lift the tongue away from obstructing the airway. And in trauma victim, where we suspect the cervical cord injury, we always go for jaw thrust, because in chin lift and head tilt, what will happen? There is movement, there would be movement on the neck joint. Okay, so I'll open the airway and then I will give a breath after pinching the nose of the patient. I will give just adequate breath. I will give just adequate breath. I can use a barrier device, a pocket mask or a barrier device, a handkerchief if I don't want to just give without using a barrier device would be good. We deliver each breath over 1 second. We note when we deliver the breath, we look the chest of the victim. We look for the chest rise of the victim, right? If there is no chest rise, I would not reattempt. I immediately after giving 2 breath, I would go for chest compression. And giving breath, interruption during giving breath should not be more than 10 seconds, right? So we should resume the chest compression immediately. 30 compression to ventilation cycle, repeated for 5 cycles. Again, I do a pulse check within 10 seconds, not more than 10 seconds. So interruption should not be more than 10 seconds. Now, if still no pulse, the cycle will go on repeating. 30 compression to ventilation. Again 5 cycles. And again, after completing 5 cycles, I will feel for the carotid pulse. No pulse, again the cycle will go on. Well, in the meanwhile, if the ambulance comes with something called automated external defibrillator, this is a special device which is a automated machine, computerized machine, which is pre-feeded with orders, and now it will give me the, once I will attach it to the victim, it will give me orders and I will have to follow the orders of this device. Now this is attached immediately once it is available. You know, if the rhythm is shockable, as soon as I give the shock, the chances of survival in the victim would increase exponentially. And the best cardiac arrest with best prognosis are the shockable rhythm. So we try to attach this defib as fast as possible, right? So remember, this is we have public access defibrillator. We call it PADS, public access defibrillator, available at most of the places where, let's say, like malls, like your airports, etc., right, to use in cardiac arrest victims. So this, it is kept in a box. Immediately you have need to open it and take the defibrillator out. Once you take the defibrillator out, you open the case of the defibrillator, that automatic external defibrillator, and the power of the AED starts. Or sometimes in few AEDs, we have an on button. So we turn it on. Once we have turned it on, we attach the pads. We attach the AED pads to the victim bare chest. We always choose the adult pads for 8 years and above, and pediatric pad for 8 years and below. And most of the defib AED has both the pads available. Okay. Now position of the pad on the chest, bare chest of the victim. There is 2 positions, anterolateral and anteroposterior. Now this is the pads. On the pad, images are made where you have to place it, right? Anterolateral, that is one pad on the right side just below the clavicle, and the other pad in the left axilla, right, in the left axilla. Remember, the anterolateral. Or we can go for anteroposterior, that is, we put the pad on the left side of the sternum, right, anteriorly and posteriorly. Okay. So this is the image of automatic external defibrillator. You can see it, and this is the pads with it. So we turn it on. Once we turn it on, the button on, it gets on. We attach the pads. When we attach the pad, once the pad is attached, the AED would start giving the command that clear the victim, let me analyze the rhythm. AED would take some time to analyze the rhythm, and that time we don't have to touch the victim. So we clear the victim for the AED to analyze it. Now AED will give the command by analyzing the rhythm, whether it's shockable or non-shockable rhythm. If the rhythm is shockable, we will charge the automatic external defibrillator. We don't need to choose the energy level because it is prefixed. Everything is prefixed in this computerized device. We clear and give the shock. And again, immediately we resume compression. AED will give the command, resume compression. We'll start compression. And once 2 minutes is gone, again AED will say, stop compression, let me analyze the rhythm. So it will go on in a cycle form. If the AED says non-shockable rhythm, then we will not charge the defibrillator and will continue compression and ventilation. Okay, so this cycle will go on, and this is all in basic life support, right? We give compression and ventilation till AED comes. Once AED comes, we attach the pad, and now we follow the command of AED, right? So this is what is basic life support and nothing else. Okay. Now there are some special circumstances of AED attachment. If the victim has a hairy chest, we need a very good contact, right, with the skin of the victim for the AED pads. Then only the heart will get defibrillated. Okay. So if the victim has a hairy chest, then the pads will not get attached properly. So we have to shave it. And every AED has a pouch with it, with a razor and scissor, etc. provided with it. So we immediately will shave it and attach. If the victim, I have pulled the victim from the water, I cannot attach the pad on a wet surface. So I'll have to wipe off very fast and then attach the pads. If the patient has a defibrillator, we'll attach AED away from defibrillator. That is implanted defibrillator. If the patient has some medicated patch, we'll attach the AED away from that patch. We can simply peel off the patch and attach the AED also, right? So in these circumstances, we have to take some special precautions. Okay, so this is all about the BLS in adult. Now there are some differences in basic life support in infant and children. The adult was the victims with, let us, above puberty and above. Now children is from 1 year to puberty. An infant is less than 1 year, excluding the newborn. Excluding the newborn, less than 1 year comes infant. Comes into infant category. Children category, 1 year to puberty. Above puberty, adult category. Okay, so what is the difference? Difference from adult. Well, right from the establishing of cardiac arrest, in adult we use carotid pulse. We felt carotid pulse. But in infant, we go for brachial pulse. We go for brachial pulse. It is easily palpable pulse. And in child, we go for either carotid or femoral. We can go for either carotid or femoral. Femoral can also be used. In adult, if there is any pulse, we consider that there is a pulse. But in pediatric, we count the pulse also. If it is less than 60 and patient has signs of poor perfusion, then we consider no pulse and start the chest compression, right? So we count it less than 60, poor perfusion, we start with chest compression. Okay, if there is only one rescuer, then the ratio is 30 compression to ventilation. Compression ventilation ratio is same as adult if there is a single rescuer. And the technique is, in infant, 2-finger chest compression. We take 2 finger, put it on the middle 1/3 of the chest and we compress it. Okay, and in child it is 1 or 2 hand, like in adult, depending upon the size of the child. If the child is a big child, then 2 hand. If it is a small child, then 1 hand would be enough for chest compression. So in single rescuer, 30:2 the ratio. And the style of the compression is, in infant 2 finger and in child 1 hand or 2 hand. If we have multiple rescuer, then the ratio changes from 30:2 to 15:2. 15 compression to ventilation. And the technique in infant, thumb encircling technique. We go on to the foot end of the infant, and in case his chest in both our hand and encircle it with it, and with our thumb we'll do a chest compression. Got it? So this is a better way of chest compression in infant and gives a better cardiac output. So when there is more than one person, we always go for this technique. Got it? Thumb encircling technique. But when I am a single person doing the rescue, then I will have to move a lot when I am practicing this technique, right, for giving breath to the patient. So in that we go for 2-finger technique and be at the side of the patient. But if I am more than one person, I can change my position and be at the foot end of the patient. Got it? And go for thumb encircling technique. Okay. Compression depth. Adult we talked about at least 5 centimeter. Children about 5 centimeter. And in infant about 4 centimeter. So second change is in the depth of compression, right? Mostly it is 1/3 of the AP diameter which we have to compress for an effective compression. Rescue breathing. In children, we have to give more breaths. Adult, it was 8 to 10 breaths per minute, independent. But if the rescue breathing in infant or child I am giving, then we are giving 1 breath every 3 to 5 seconds. That is 12 to 20 breaths per minute. Got it? So we are giving little more breath. We are keeping the respiratory rate little higher than adult in children and infant. Okay? So remember, it is 3 to 5 per second. Every 3 to 5 seconds I give a breath in children. If I am going independent of compression, giving breath to the child. Okay? Otherwise, we follow the ratio. Generally, we follow the ratio. But if I am giving it independently, a 2-person, we have put advanced airway, then 3 to 5, every 3 to 5 seconds, I will give a breath. Okay? Okay. Defibrillation, for less than 8 years, we use child pads, remember. And if child pad is not available, we can use adult pad. But in an adult, we never use child pad because it will not give the adequate shock, right? Adequate energy of the shock. And only thing which we have to keep a precaution in child if I'm using adult pad, that two pad, it's a bigger pad, so it should not touch each other. So we go for anterior-posterior, right? So now let us just in a tabular form go through the differences, right? So in adults and adolescents, and in child 1 year to puberty, and infant less than 1 year. First step in everyone is scene safety. We make sure the environment is safe for rescuer and the victim. For recognizing the cardiac arrest, for establishing the cardiac arrest in adult, we check carotid. In pediatric, carotid or femoral, and in infant, brachial. Right? Activation of EMS is done in the same way. We activate EMS and start CPR in adult. If in child or infant it is a witnessed arrest, the arrest has happened in front of me, so we do the same thing. We activate EMS and then start compression, chest compression. But if it is unwitnessed arrest, then we give one cycle, that is 2 minutes CPR, that is 5 cycle. 2 minutes CPR, that is 5 cycle. Give 2 minutes CPR and then activate EMS. Got it? Because the oxygen in children, it is mostly the hypoxic causes is the most important cause for the arrest. So we have to, like, oxygen content of the body is less, so we very fast we need to give the 5 cycles and then activate the EMS system. Okay, then they have a better chance. Okay. Compression ventilation in adult, any number of rescue, it's 32. In child and infant, one rescuer 32, 2 or more 15:2. Okay. Now, if I am doing a compression and ventilation with an advanced airway in the place, then I have to do it independently of each other. Then we give a continuous compression at the rate of 100 to 120 per minute and give one breath every 6 seconds, right? Every 4 to 6 seconds in child and infant. So in child and infant, every 4 to 6 seconds I give a breath, right? That is 12 to 20 breath per minute. And in adult, we give 8 to 10 breath per minute, right? 8 to 10 breath per minute in 1 minute. Okay. So in children, rate I have to keep the respiratory breath delivering rate, I have to keep little higher. The compression depth, as we discussed, 5 centimeter at least in adult, about 5 centimeter in child, and about 4 centimeter in infant. Now, technique of chest compression in adult, always 2 hand on the lower half of the sternum. In child, 2 or 1 hand at the lower half of the sternum, and in infant, if single rescuer, 2 finger technique. One rescuer, 2 finger in the center of the chest, just below the nipple, right? And if 2 rescuer, then thumb encircling technique, which is a better technique for chest compression. In all, we have to allow a complete chest recoil and we have to minimize the interruption, right? So this is the differences which we need to know in the resuscitation of adult, pediatric and infant. Okay. Now before ending the BLS, let us talk about choking. What do I mean by choking? Choking means any obstruction of the airway, complete obstruction of the airway, right, partial or leading to absolute obstruction of the airway, which would prevent any air passage. We call it choking, right? And there is a first aid maneuver which is useful in a choking victim, which can relieve the choking victim, right? And that maneuver is called Heimlich's maneuver. So something called Heimlich's maneuver. This is a simple life-saving technique which we use in a choking victim and relieve him of airway obstruction. So what we do in Heimlich's maneuver, we go behind the victim, encircle his abdomen with both of our hands, make a fist out of one hand and put it just below the umbilicus, right? And encircle our one hand, the fist with the other hand, and we push backward and upward. We give an abdominal thrust backward and upward. This will increase the intrathoracic pressure and will force the substance which is obstructing the airway out of the oral cavity. Okay, so we call it Heimlich's maneuver. So we go behind the victim and give abdominal thrust by taking a fist and putting the fist just below the umbilicus, encircling the fist with other hand and giving a pressure backward and upward. Okay, this is called Heimlich's maneuver, as you can see in the image. So this image can be asked in exam and can ask what procedure is being done, right? This is Heimlich's maneuver to relieve choking victim. Okay, in infant, let's say in infant, in let's say less than 1 year, this Heimlich's maneuver, the technique is different. Now it is called back slaps and chest thrust. What is done? The victim is, the rescuer sits on a chair, hold the child in his hand, right, in one of the let's say forearm, hold the child as you can see in the image on his forearm, and put his hand on the face of the child, and with his other free hand give 5 back slaps. So we give 5 back slaps. Okay, and once I have given 5 back slaps, I make this child in supine position. So I am giving 5 back slaps and then I am rotating the child on my other hand and make him supine, and with other free hand I give 5 chest thrust, right? I give 5 chest thrust. After giving this, I open the mouth of the child and try to see if the foreign body has come in the oral cavity. If it has, then I take it out. If I cannot see any foreign body or anything, so again I will go for back slap and chest thrust. I will go on doing so till the foreign body comes in the oral cavity or till the child becomes unresponsive. Well, we give these first aid only till the time when the person who is choking is responsive. Once the person becomes unresponsive, then we have to go for basic life support, that is CPR, chest compression and ventilation. So these maneuvers in a choking victim is done only till the person is still, let's say, not unresponsive, still responsive. So Heimlich maneuver is done till the person is responsive. Once the adult becomes unresponsive, we go for CPR, chest compression and ventilation. So anyone becomes unresponsive, right, we go for analyzing and that when person is in cardiac arrest or not, and we go for the CPR, chest compression and ventilation. Got my point? Even same for the child. Till the child is responsive, we go for back slap and chest thrust. Once the child becomes unresponsive, we go for CPR. So this was how we relieve a choking victim, right? So this is all I wanted to discuss in BLS. After BLS, I will discuss with you ACLS in the next chapter.